Thank you, Dr. Sandeep Rai, for kind introduction. So let me first thank respected Dr. Boraskar sir, Dr. Bansi, Dr. Manoj, Dr. Purvi, and the entire DRS team for making me part of this prestigious event. And today I will be speaking about highs following the lows. So in insulin requiring diabetes, symptomatic hypoglycemia can motivate aggressive carbohydrate intake beyond what is required to restore to normal blood glucose levels, and this can result in rebound hyperglycemia, or what is now being termed as post-hypoglycemic hyperglycemia, and this may involve then bolusing, and that will result in further hypoglycemia, and that will result in contribute to glycemic variability. So what is post-hypoglycemic hyperglycemia? This is a study from Belgium, the EPICHA study, where they have tried to coin this term. This is hyperglycemia following a hypoglycemic episode within a period of maximum of 2 hours. If you see this CGM profile, here there is an onset of hypoglycemia, here there is end of hypoglycemia, and within 2 hours the blood glucose crosses 160, and then this is being termed as hyperglycemia. This is onset of post-hypoglycemic hyperglycemia. This is overall duration of post-hypoglycemic hyperglycemia, and this is the mean hyperglycemic peak of post-hypoglycemic hyperglycemia. So PHH, there are 3 things you have to know. One is the frequency of PHH, second is the duration, and the severity as demonstrated by the peak, which is achieved during the hyperglycemic phase. This can be because of either excess of carbohydrate intake during hypoglycemia most of the time, or it can be because of lack of insulin coverage or modification of physical activity, and last but not least, the controversial Somogyi effect. Somogyi effect, we all know, hypoglycemia, it will result in surge in counter-regulatory hormones, and that contributes to hyperglycemia as suggested by Michael Somogyi, and that is generally asymptomatic nocturnal hypoglycemia that will be followed by a early morning hyperglycemia because of surge of counter-regulatory hormones. That is what is suggested by Michael Somogyi, who was a Hungarian professor of biochemistry and who developed first time the method of urine glucose estimation for monitoring of glucose control. And he first demonstrated this on the basis of case reports of 3 patients which were admitted in his hospital recurrently for either DK or hypoglycemia during his tenure as a biochemist at this hospital in Missouri. So these were the patients who were having brittle diabetes. In those days, glucose monitoring was not available. So they tried to adjust insulin dose based on the urine glucose monitoring. They collect urine sample from breakfast to lunch, lunch to supper, supper to breakfast, and the entire sample they calculate the total amount of urine sugar, and based on that they do adjustment of insulin dose. So this was the way they were practicing diabetes in those days in 1950s. And based on his experiments, he come out with the conclusion that days where the urine sugar are very low, they are immediately followed by days of high urine sugar. That means the days of hypoglycemia, they are immediately followed by days of hyperglycemia, and same happens also during the daytime. If there is a period of low urine glucose between breakfast and lunch, following lunch, there will be high urine sugar. So they suggested that the hypoglycemia results in release of counter-regulatory hormones, and that results in hyperglycemia, and that is what the basis of Michael Somogyi's this experiment that suggested that morning hyperglycemia in response to asymptomatic nocturnal hypoglycemia, and this is being termed as Somogyi phenomenon. However, this is very controversial. Lot of studies they have refuted this hypothesis. This is one of the studies, 15 patients, asymptomatic nocturnal hypoglycemia. Few of them, they were having high fasting plasma glucose. Then they have tried to correlate it with the counter-regulatory hormones and the free insulin levels. And they concluded that the hyperglycemia is because of the low insulin concentration and not because of the counter-regulatory hormone release. And a beautiful review ultimately concluded that under most circumstances, unless food is taken to relieve symptoms, nocturnal hypoglycemia does not lead to a rapid increase in blood glucose level, and hypoglycemia can persist for hours, particularly in insulin patients who are fasting. Eventual increase generally occurs either because of food intake or because of low insulin level and not because of counter-regulatory hormone release. So counter-regulatory hormone release contributing to hyperglycemia, it is very, very hypothetical, and generally it is not being accepted as a cause of post-hypoglycemic hyperglycemia. CGM can very well identify this. This is one of the data. People who were having asymptomatic nocturnal hypoglycemia and their morning blood glucose, if it is measured, then most of the time it is less than 5 millimole per liter. So less than 90 milligram, and very less time it is more than 140 milligram per DL. So this again questions the Somogy hypothesis. Another study done by Professor Simon Heller, who was there in the audience in the morning, they have tried to correlate lowest overnight sensor glucose with the fasting capillary glucose, and they concluded that lower the overnight sensor glucose, the same way the fasting capillary glucose will be lower. So it is not with low overnight glucose the fasting glucose increases. So it is rather vice versa. So if fasting glucose is low, there are all the chances that the patient is having nocturnal hypoglycemia. And the same has been proven from this CGM data of 2,600 patients with type 2 diabetes, and they clearly shown that if fasting is less than 70, there is 100% probability of nocturnal hypoglycemia, and if it is more than 170, then there is no risk of nocturnal hypoglycemia. So hypoglycemia does not result into sufficient counter-regulatory hormone release that contributes to hyperglycemia. So most of the time it is because of food intake. This is the study which I was suggesting at the beginning of my talk, which coined this term post-hypoglycemic hyperglycemia, and this was done in 142 pediatric patients over a 2-month period, and they have tried to find out various factors which are contributing to PHH, and their suggestion was that most of the time it is related to inappropriate food intake to counter hypoglycemia, which results in hyperglycemia. Generally, the episodes were of 4 hours duration, and peak achieved was around 260.6 to 0.3 episode per day, and they correlated very well with the hyperglycemia rate. They contributed to overall 22% of hyperglycemia throughout the day, and around 1/3 of patients, they contributed to more than 35% of hyperglycemia throughout the day that was contributed by post-hypoglycemic hyperglycemia. Younger people, lower BMI, they are having higher frequency of post-hypoglycemic hyperglycemia, but they were of shorter duration, shorter intensity, whereas teenagers and obese patients, they were having although lower frequency of post-hypoglycemic hyperglycemia, but they were of longer duration and they were of higher amplitude or higher severity. This is important because there are evidences to support that if you recover from hypoglycemia into the hyperglycemic zone, not into the normoglycemic zone, then this can affect your endothelial function, it can increase oxidative stress, it can increase inflammation, it can result in thrombosis activation, and this may contribute to increased cardiovascular risk in people with type 1 diabetes. Therefore, you need to focus on this post-hypoglycemic hyperglycemia also. And this is one of the examples of type 1 diabetic on CGM at night developed hypoglycemia, took a large snack, sugars increase, in the morning he reduced the dose of bolus insulin, there was a further rise. So this is classical post-hypoglycemic hyperglycemia, which is shown there. It requires a lot of patient education and counseling to prevent this kind of post-hypoglycemic hyperglycemia. Also, nasal glucagon, instead of an injectable glucagon, it also associated with lower chances of having rebound hyperglycemia or post-hypoglycemic hyperglycemia. And at the same time, we can use technology, particularly real-time CGM and the predictive alarms for hypoglycemia. They can help us in preventing this kind of rebound hyperglycemia. So with that, I end my presentation. Thank you very much. Thank you, Manoj, for giving me this interesting topic of the highs following the lows. Thank you.